We can go ahead and get started. My name is Rachel Mark. I am, well, first, can everyone hear me? Okay. Perfect. Okay, thanks. I am one of the co-chairs for the Primary Care Behavioral Health Special Interest Group. Today's general meeting is going to be a little more informal than other meetings that we've had. Today's topic is clinic culture. We want to have this, we're going to have Dr. Bruner talk to us a little bit about his experience with a clinic culture that he came into. And then I'd also love to hear from other people about the clinic culture that they're currently in, that they've been in the past, what's worked, what hasn't worked. I think right now, given all of the changes that are impacting federally qualified health centers, any center that is receiving funding, working with marginalized populations, I think now is an important time to discuss, like, how can we create a clinic where people are able to do the best care or to take the best care of their patients and provide an environment where patients feel safe. And so we're going to spend a little bit of time talking about that. Usually we have some announcements. We don't really have announcements today. We'll have another general meeting in about 2 months. And then, of course, if there are any suggestions for meeting topics or any job announcements that anyone would like to share, you can always put it in the chat box or just let the group know. So, Dr. Bruner, are you feeling good to start us off?
Sure. Yeah,
Okay.
happy to do it. Hey all, if you don't know me, I am Dr. Mike Bruner, I'm a clinical psychologist. I am the Director of Behavioral Health at Health Source of Ohio, a big FQHC in Southern Ohio. So I've been here at Health Source for like 6.5 years, I think. And this is my first like grown-up job. You know, I came straight here from postdoc. And I remember when they were first kind of talking to me about coming on and looking at, clinics to start me at, because the idea was that, because they were brand new to integrated care, to primary care behavioral health. And so the idea was to do this smart and slow. I would come in basically just as a BHC at one clinic, pilot the model there, and then if once we kind of fine-tune things, then spread out to other clinics, and then as it grew, like my role in leadership would grow. So I remember when we were looking for the right location, basically we chose based on two things. One was the closest for me, because we're kind of more on the eastern, like kind of east of Cincinnati, and I live in Westchester, which, as you might guess, is west. And so that and the culture at that clinic was really poor. And they were hoping that I might be able to help with that. And so, I'm bright-eyed and bushy-tailed coming out of postdoc. I'm like, cool, like, let me at it, So spoiler alert, it takes a lot more than one person to make those kind of changes. But yeah, so it was pretty rough when I got there, and there were a lot of different things that I think contributed to that. There were kind of some problems morale-wise, like at the provider level and at the support staff level, and just kind of across the board. There had also been like a big problem with turnover, and for anyone that hasn't had this experience, turnover seems to be like self-perpetuating, because you'll get new people, but then they get there and they're like, wow, this sucks, and they leave. So, that was probably one of the biggest problems we had. And that kind of went into with the practice managers too. Like we went through, I don't know, 5 practice managers in 2 years or something like that. So it was really rough. It was really rough. And my enthusiasm kind of fizzled out pretty quickly on that. So I don't know. I don't know, like what kind of stuff should I talk about in terms of like what it was like there? I'm pretty ADD, so I don't know like what details to put in and what to leave out and things like that. What
It's
would y'all like to
totally
know?
fine. I know you mentioned a little bit like with the providers, there was a little bit of like this negative culture and with support staff. Like when you started at this clinic, what was your take on everything that was going on? Like what were you witnessing?
Yeah, like I said, a few different things, but we had uh, we had one specific provider who just had really unrealistic expectations. Like I'm trying to think of some examples. They wanted like a very disproportionate kind of portion of the support staff resources. At one point, I think they were talking about wanting two MAs. And to be fair, this person was highly productive, so there was some validity to it, but yeah, very demanding in that way, kind of expecting people to like just know things that the person wanted, and just like I said, in general, just expecting, there's so many, you have one MA if you're a provider, but expecting like everyone to kind of help them because they were more busy, basically. Which, if you're in a good quality primary care team, that should indeed happen, right?
Mhm.
But not in the way that this person was expecting. So there was that. And then I still recall that there were some support staff, a front desk person, some of the MAs. I don't want to be put like a judgmental spin on it, but
Sure.
honestly, they just had kind of like a bad attitude. I hate, when a patient says that about or a parent says that about one of their kids that I'm seeing, like I hate that, but I'm gonna go ahead and use those words, right? Just kind of looking at the most negative aspect of everything about the job. Now, obviously, we can look at context on that, like maybe it's when the culture is bad, it's kind of, again, it's like this vicious cycle, right?
Mhm.
But that was definitely part of it too, is just kind of classic stuff that humans do, right? All of us are prone to focusing on the more negative, threatening aspects of any situation by nature. And so just doing a lot of that, a lot of one of the things that shocked me the most was just the way people would talk about the patients. So there was like an MA, long gone now, but if there was like a handoff, they would say like out loud that anyone kind of like within 20 feet could hear wackadoodle in number 5 or like something like that. And so not great, not great. Um, so there was a lot of that kind of stuff going on, and just that bled into with patients, we had a lot of patient complaints and stuff, but also internally, right? Just kind of the
Sure.
negativity feeding off the negativity. So it was,
Mhm.
yeah, not great.
And were you the only BHC there at the time?
Hmm.
Okay. And
Yeah,
was
I
this
was the
new?
first. Yeah, it was brand new. We before that, Health Source had some co-located therapists, and there had actually been one there, like very close. She might have even overlapped with me for like a week, um, but again, very typical co-located therapist, like not really engaged in the team. Just kind of spent her time in her office, would go grab people, go back. But yeah, they hired me to build PCBH there at Health Source overall, and that was the clinic that we were starting at. So yeah, it was brand new to everybody.
Okay. And whenever we add in a new team member or a new department, that can definitely have an effect on the clinic as a whole. Did you notice any of that? Like any ripple effects from you being new on the
Yeah,
team?
I did. And what I noticed, it was interesting, right? I noticed that it did for some people and it didn't for some people. But yeah, definitely, the people that utilized me more, I think, felt a lot better. When I was able to be helpful, it reduced stress because I think, that's always, people are rarely this way in a context where everything's stress-free and hunky-dory, right? So I think that was really helpful. I'm also just like a very bouncy, energetic, like super stereotypical BHC, right? Just and I just love trying to make everybody happy and stuff. That's kind of how I get my my self-esteem, I guess. So yeah, I did a lot of that. and just kind of validating people. A lot of like Psych 101, right? Like, so selectively
Mhm.
reinforcing. I remember thinking a lot about like validating people's distress, praising, reinforcing, and like ignoring kind of the more problematic behaviors. And I definitely saw that with some people that had an effect like relatively quickly, like within the first month, I would say. And then I noticed that with other people, they were super cool and nice to me, but it didn't really change anything outside of that. So yeah.
Okay. So mixed response, it sounds like.
Yeah. Yeah,
Um, when you ever, I'm sure it was not just you. I'm sure you needed a team effort to kind of make some of
definitely.
these changes, but how did you prioritize like what you wanted to work on first or what you wanted to see change in first?
You know, I had to prioritize is a good word because obviously like the culture was important to me and it was something I was thinking about from the beginning because they had brought up like we're hoping maybe as a side effect you being there might improve this. That being said, my priority was kind of the basic like PCBH implementation. So I was focusing on the work and I was trying to think about through doing the work, can I kind of push the needle a little bit in the right direction. So when you say priority, that's the main thing was just like, scrubbing or scrubbing PCB schedules, jumping in like when people were behind and stressed out, like, hey, I can do that med check for you, and then you can get back on schedule, those kinds of things. Other than that, like I said, just being a good BHC, not hiding in my office, being there at the counter where all the stuff is happening, right? Like where people are complaining or kind of I don't know, just being negative or whatever in general, by being there and trying to just proactively be more positive and cheerful, trying to draw. One thing I remember doing is drawing attention to like the value of what we do. So I think one thing that I see sometimes that can contribute to negative culture, at least for us, like in an FQHC serving the underserved, is like expectation management. You kind of need to realize going into it that it is a tough job. Like at
Mhm.
baseline, it's stressful, um, dealing with the kind of problems that our patients have. And so trying to draw attention to how we were helpful, how we made a change in someone's life. I tried to watch for things that even the support staff did that I could kind of draw attention to. And obviously, we're all adults, so it can't be this really goofy, like, oh my gosh, you did such a good job, but just kind of subtly drawing attention to those things and kind of connecting it to the meaning and the value behind that. Um, I'm sure there were other things, but that's what jumps out at me.
Yeah. So like the presence of even just being the presence available around the staff members, kind of pointing these things out. What do you feel like was the biggest change that you saw?
Good question. Um, I think I would say there were a couple of the providers that I think really did good on the uptake with kind
Mhm.
of like picking up what I was laying down, so to speak. And I was well received, and that's fortunately been the case across HSO, but I was well received, so I didn't have any problems, but even so, the team is just kind of pre-programmed to put more stock in the medical providers, right? Which is totally fine. And so I think once a couple of them kind of saw what I was doing, and I think one of them actually I was a little more explicit with about like, hey, this is part of why they wanted me to be here. I'm trying to work on this. And she was pretty cool about like helping me. And so getting the medical clinician like support on that and having them kind of help me out was probably the biggest thing. I will say, I mean, I don't know if this kind of like spoils the talk, right? But like some of the things that were most important were some of those more basic things like sometimes people just aren't going to play ball, and so getting rid of those people basically.
Mhm.
And I think that one of when things finally there was a tipping point. Let me put it that way. There was a tipping point. And I had mentioned before about how the turnover can kind of perpetuate more turnover. And that was a really rough thing to deal with. So I remember when I realized that we had gotten a couple good MAs. And so I really focused on them really seriously. Like I really constantly checking on their wellness, just like supporting them, making them feel important, validating them, reinforcing them for being kind of more optimistic and helpful and things like that. And I'm not saying that's just because I did that, but what eventually happened was we held on to enough people that we reached a tipping point where things changed long enough that then we held on to those people, and the new people we got stayed too. And then we got a good practice manager that was like an internal promotion, and that stability made a huge difference. So I think that's the main thing, is when we had that tipping point of holding on to people long enough that we had a full staff, and then that reduced stress, and then we were able to keep it going. So
Right. Yeah. It's like you want to get the buy-in from them. It's like with our patients. Like we can tell you all
Sure.
these things to do and like we can say this is going to be helpful, but if they're not bought in, we're just not going to see that change.
100%.
Yeah. So what's the clinic there? Like what's the culture like now there? Are you still at the same clinic?
Yeah.
Okay,
I only
sweet.
see patients half the time now, but I'm still there the other half, and I've got prac students there. Um, but it's great, honestly. I'm not saying that it's always perfect, right? We
Sure.
have drama, as they say, and sometimes people bicker and stuff like that, but none of it is super impactful in an adverse way, So I hear a lot more of people just talking about the good we do, which I think is really important for all of us, to just kind of feel that sense of meaning and how that aligns with our values. Um, we have just a lot more. It's a different practice manager now, but she's amazing, and having good leadership, I think, has helped a lot. Very kind of organized and proactive. Um, and I think that helps people feel like their concerns and their needs are important. And so that makes a big difference. But yeah, overall, really positive. It's quite the change. I mean, we haven't, I'm trying to think. I can't remember the last time we lost somebody because they hated the job and quit, So um there have been people that have had to move on for other reasons, but I don't know, it's been at least a year. I think a lot longer than that, but I don't know if that sounds good or bad to all of you with your personal experiences. But for us, for a long time, a year is quite the feat. So, but I'm pretty sure it's been a lot longer than that. But yeah,
That's huge. That is huge.
right? Yeah,
Maybe some people, yeah, like depending on your clinic, 1 year doesn't sound like so long, but definitely like at our clinic, that's huge. When we get someone new and they're like,
100%.
they hit the year mark, we're like, okay, I think we got them. I think they're gonna stick
Yeah,
around.
yeah, totally. Yeah, it's been pretty cool. Yeah, it's been really cool to see. I actually talk about it a lot, and I hear other people talk about it, which I don't know, when it comes up in normal conversation, I feel like that's a really good sign if other people are noticing, that it's a fun place to be. So,
Mhm. If you were in this position again and you had to do it all over again, what, or,
oof,
you were mentoring someone who did,
yeah.
what advice would you give them?
Um, wow, great question. There's a couple things that are coming to mind.
Hmm.
One is I would kind of coach that person on being more assertive and confident in their ability to help. I'm not a super assertive person by nature. I'm not really good with confrontation and stuff like that. And so I was kind of trying to work in the background, guerrilla warfare kind of thing. But if I came in today, I'm so much more confident in myself and my role and what I bring to the table that I think I could have done a lot more, just being more active and kind of transparent about what I was
Hmm.
doing. And so that would be one thing that I would just tell people to believe in your abilities here, I think that does have to come along with being like clinically pretty competent. Like you have to
Mhm.
be able to, you have to be helping in the clinic, so that what you say matters to the people, right? But I would imagine that's pretty much the norm. So the other thing is, again, it's less warm and fuzzy, but I would, again, this is part of being more confident and stuff, but I would have been going back to the leadership that had sent me there for that purpose and just said, hey, here's what I think I can do and what I don't think I can do. And honestly, the biggest problem here is some of these people, and I don't know if they're teachable. I don't know if they're
Mhm.
willing. Um, and like the main people that were problematic, by the way, they all ended up getting fired for things that were unrelated to this.
Interesting.
Um, so now going back, I would go and be assertive with my leadership, my boss, and the other like the ops people and stuff, and just say, hey, like, I mean, if there's something you haven't done yet that you can do, that you can intervene, and you think that you can make some headway here, go for it. But I'm here to tell you that I think sometimes people just have to go, and I
Mhm.
think that's something we don't like to talk about. We like to think that we can fix any problem, but one of the things we know as clinicians, right, is that Rachel, I think you said something about it earlier, right? Like we can say all the things, like we can be the most skilled clinician. It's still always up to people whether they want to make the change, right? Whether that fits for them. And we don't have to be judgmental about it. It's like, hey, you can keep being the way you want to be. That's fine. You just can't do it here. Like you have to
Mhm.
find somewhere else to be that way. Um, so yeah, I mean, I don't want to be too negative. I know that that's, again, we don't like thinking about the fact that sometimes we just need to get people off our team. But I've done a boatload of like research, reading on like leadership, organizational development, all that kind of stuff in these 6 years, and that is something that comes up again and again. They talk about like hire slow, fire fast, and things like that. So
And I think there's a lot of validity, even though it may not be like the fuzziest part of this conversation.
yeah.
I mean, I've noticed in our clinic, I haven't been here that long. I've been here 2.5 years, but um, I have noticed like sometimes it'll wax and wane with how our clinic culture is. And a lot of times it's unfortunately tied to like the interactions between either a new hire and people who've come in or people who've been here a long time. And a lot of times it has been resolved when that person decided to leave. But that doesn't mean, we didn't try to make things work and turn things for the better while they were still here. But I think it is valid. Like sometimes this is just not the place for them. This is just not the role for them. And
100%.
especially if it's impacting not only, the way that the staff interacts, but also like patients pick up on this stuff. Like our
Oh
patients
yeah,
are very smart. They pick up on what's going on
100%.
around them.
Definitely. I mean, I mean, be transparent, right? Like, go look at some of our old Google reviews. Like, they're not great. And I mean, granted, like, no news is good news, right? Like, patients tend to, are much more prone to leaving reviews when they have a negative experience than a positive
Mhm.
experience. But still, 100% patients picked up on this stuff. I remember a great example that now I'm just kind of gossiping, I guess, but there was a particular front desk person that was very problematic, and we actually tried really hard to work with that person. We gave him a lot of chances, but I had, in the course of a month, I had two patients who, at the end of the visit with me, asked me if I would schedule the follow-up for them. And I was like, I mean, sure, I can do that, but why, right? It took me a couple minutes to get it out of them, but they were afraid that that would be the person that, like the other two would be busy and they would have to talk to that person. And so that was when I was like, that was later. That was one of the last things that happened. And I was assertive enough at that point to go and kind of say, hey, like, if I have patients that are afraid to go to the front desk, like something needs to happen here.
Mhm.
So
Yeah. And I think, a part of this conversation is patient safety. Like patients want to feel like
yeah,
they can
yeah,
interact with any team member and feel welcomed by them. And sometimes that's not always the case.
yeah, of
Um, well, thank you for sharing your experience.
course.
It's really helpful. And I am curious to know if anyone else in the meeting today has any experiences either similar or different from any that Dr. Bruner shared with us. Like, what is your clinic like? What have you noticed when you came in, or what have you built?
Share. We have so our I work with a company called Air Support, and we are fairly new, very new actually. But we have like only a handful of employees, and so what we've tried to do as far as like making our team a little bit more cohesive is we have like skill sessions on Tuesdays where we kind of talk about like we make it into a workshop where we talk about things that are impacting patient care. And then on Fridays, we kind of during our morning huddle, we'll talk about some wins that we've had and or some reflections that we've had about the week if we don't have any wins. And I think that that helps us feel a little bit closer as a team. And I think that the patients, when we are doing like intake and assessments, I think the patients can tell that we are really kind of getting along and they have a good experience. So I think like Dr. Bruner was saying, no news is good news. So we don't have any bad reviews, but people can tell that we get along well and that we are there like as a supportive. They don't have to worry about the security of our team when they're trying to fix their stuff.
Hmm. And Dr. Rivers, what that kind of that programming you'll have during the week of like meeting together at the end of the week and in the middle of the week, has that always been a part of your clinic, or is that something that was newly implemented?
So the workshops in the middle of the week, those are new. Um, and it was just it just came from like our peer support specialists having questions like, well, what do we do when this part, like patients have this sort of issue that I'm not familiar with, or like, what do we do when people have this kind of boundaries? Or we had a conversation about like unlearning homophobia. So that kind of started the first series of sessions where it was like facilitating the unlearning of certain systems.
Mhm.
And it just had some really good conversation pieces that came out of our huddles. So it's new to answer your question.
Yeah, yeah. Well, it sounds like a big piece of it was like collaboration between everyone and like drawing on the skill sets that each person had.
Yeah.
Thanks for sharing that. That's helpful.
Yeah.
Anyone else have any experiences with um, either changing the clinic culture or just observing how things have been over your time at your clinic? Again, today was very informal, so
Hello. I guess I'll speak.
hey.
I'm Lana. I work at, I guess, maybe a larger FQHC. We've got like 10 different locations. Um, and most of our BHCs are assigned to multiple locations. And I've been there for 6.5 years now. So I've kind of seen the ebb and flow across different clinics as we've had turnover. And especially as the pandemic affected us, because at one point, all of the BHCs were sent home to work remotely so we could reduce the number of staff in the clinic. And then, of course, there was huge turnover because of COVID, people leaving the field. And so it was really interesting to see some clinics, have this building of good culture and BHCs really being integrated and things were kind of like, all right, we're getting a roll on with things here with integration. And then COVID happened and it just felt like it decimated everything. And so now we're in a place now where we're still trying to rebuild because our BHC team went from like a team of, I want to say we had 9 like full-time BHCs, and now we've got like 5 or 6, which is why we're split across clinics, but we've maintained a hybrid schedule so that we can try to cover multiple clinics. Because it's like when you're in the clinic, you're like really laser focused in on being present in the clinic that you're at. So the other clinics that you're covering, it's kind of harder. So anyway, we're still in kind of, I think, a rebuilding space. And I'm hoping that it's getting better because we're strongly advocating for more support staff support to help with getting patients on our schedules. So we'll see how it goes, but I'm feeling optimistic, feeling like we're coming out of that difficult space and building towards something better.
Mhm. And Elena, I was actually an intern at some of your clinics during grad
Ah,
school. And so it is like to kind of tap on the clinic culture, like each different clinic has its own different culture, and it's something you can kind of pick up on when you go. Not that's not saying it's good or bad, but it definitely like each location has a little bit of its own flavor of a culture.
mm-hmm.
But I'm curious, like, what was the response when it went like with the hybrid model, whether from patients, providers, BHCs?
Mm-hmm. Yeah. Um, it's been it's been difficult. I mean, the BHCs love it,
Sure.
but I think because it's beneficial to their personal lives more than anything. I think that there is some some frustration with being out of sight, out of mind, and staff members at the clinics just have never really gotten on board with using technology to bridge the gap.
Mm,
You know, they have iPads that they can wheel into the rooms and use for like a Zoom call, a video call, and have it still be sort of integrated with the visit, and they just have never really gotten on board with it. We have one
mm,
clinic that has more consistently done that, and that's it. None of the other ones even really know how to do it. And then even with that, there's still barriers. If we need to use an interpreter, then that gets difficult to use an interpreter and try to do a video call when you're remote. And that gap just has not been bridged.
right.
So it's put BHCs in a place of having to do a lot of um, kind of s- schedule scrubbing
Mhm.
and reaching out to patients almost like very siloed. Um, and so it's sort of like, all right, we need to get on board with better integration, or else kind of like the eventual consequence is going to be that BHCs just need to be back in clinic 5 days a week.
Sure.
You know, and they don't
It-
want that. So,
Sure. It's like
um,
a double-edged sword, like being able to have your BHEs be hybrid, they have the opportunity to connect with more patients because that way it sounds like they're kind of covering a couple clinics, but when they're
mhm.
in person, they may not be able to do that, but then also they have the presence in that clinic. And so it's like
Yeah.
risk benefit, I guess.
Yeah, and there's been a lot of that too. And it's, when you're working hybrid, a lot of times you're contacting patients after the fact, right? So it's
Mhm.
like they're on the road now, they're back at work. If it for the kiddos especially, it's like, well, they had to go back to school. They're in class now. You can talk to the parent perhaps, but maybe not the child. Or you have to schedule for the next day or the day after that, in that window between like 3:30 and 5 o'clock after they get
Mhm.
home from school. So there's definitely some barriers and some difficulties with that. And the other piece is that if we have BHCs go back into clinic 5 days a week, how is that going to affect whether or not they want to maintain employment with our company
Mhm.
versus going into private practice or going to some other job where they can work 100% remote. Um, and hiring has been a huge challenge for us.
It's been for us too. So I feel we're probably pulling from the same pool, but yeah, I understand what you're saying. Um, and I think that's fair of like again the risk benefit, like what serves our employees and what also serves our patients during all of this. Um, anyone else with anything to share about their own clinic or anything that we've discussed today?
I would just say, going back to the recruitment and stuff, we have a lot of trainees, relatively speaking, trying to grow our own. And I will say that trainees tend to, at least in our experience, they're like very optimistic, very like energetic. Like they definitely bring a good vibe both to the team and to the BHC team and to their relative primary care teams. They're, you know, eager to, you know, work hard and do all the things. And so I don't know if that's even something that you all can think about, but it's been a huge boon for us, short term and long term.
Sure. Yeah.
Thank you for mentioning trainings. I'm kind of on this call as I'm a spy, but in my previous on ground work, I was a BHC and I resonate with your experience, Dr. Bruner. I was a postdoc, only one there, responsible for like getting integrated care PCBH off the ground for children in pediatrics and family medicine. They had it in adult, and I kept on saying, children are not little adults. We have to think about this a little bit differently. Worked there for several years. And then now I've kind of shifted to teaching. So currently I'm a program director in a clinical psychology program. I coordinate our integrated health track, and kind of responsible for that curriculum. And so I'm always kind of coming to these meetings to hear what's going on so I can bring it back to students, which I didn't have when I was a trainee, kind of learning on the job experience and reading articles and being part of this organization since 2014, but I won't say so much about that. Anywho, you're mentioning trainees, and I'd love to hear from you or other folks, like what to take back to people who are still kind of starting off in their learning about like clinic culture, about like what you said about being present and being confident in the skill set and being able to kind of like, I think you said speak up and be active and be visible, like other things that would be helpful for trainees wanting to go into PCBH that would be helpful for them to know before they get there.
Oof. I feel like I could talk about that for 5 hours all by itself, but which is like, ironically, then it's like, wait, what do I say next? So I think I talk a lot about I promote us with so far we just take our practicum students from Xavier University because that's my alum, and so far they've filled all our spots. But the postdocs come from much farther out, and we'll be doing an internship. We'll be joining the match for the next match, so it'll be much broader. But I really promote PCBH as like an awesome place to train. I really hype it up as like, if you want to be good, you should come here, regardless of what kind of work you want to do later. And so I feel like that's one thing that I do a lot to try to bring people in. And my main reason for thinking that is just the number of different people you see. I feel like you can learn a lot and a lot faster by seeing lots of different humans versus seeing the same humans a lot more. So, and my trainees would agree with that. We take pretty good care of our trainees. I mean, you know, we pay them the rate that is kind of the going rate, I guess. You know, there are a lot of practicum placements that don't pay or they pay less, but we pay ours like $15 an hour is basically what it works out to, which Xavier tells me is sort of the going rate. They also get all of the, like, any gifts that HSO, like, you know, like we just for Providers Week or Day or whatever it was, we got these, you know, nice tote bags, and, you know, the students, you know, get all that stuff too. We just go out of our way to treat them like providers. I mean, I even tell my trainees, like, I'll treat you as much as a colleague as you let me, basically. So, you know, if you're cool and do a good job, you know, most of the time we'll just act like we're colleagues, and, you know, I'm your senior colleague that's coaching you. That's just my style. But I think the students really value that, and it makes them want to do a really good job. Let's see. This is more for you than for them, I guess, all this stuff I'm saying, huh? I don't know. Help me out. Ask me more questions. I'm good at answering questions, but if you let me go too long, I just start rambling about random things.
I guess if you're thinking about lessons, like you were a postdoc, like lessons learned about clinic culture, that would be helpful
Okay.
to know
Yes.
before getting
Yes.
into the clinic.
Okay. So I think a couple things. I'm thinking of, like, what would I like to know? I think sort of like a balanced, almost like a dialectical kind of way of thinking, where I would want to be, I wish I would have been coached on the one hand, like I said before, like don't sell yourself short, like you could do a lot. You could be like a big force for a positive clinic culture. And at the same time, I tend to, at least me personally, I'm one of those people that, thinks I need to like fix everything and support everybody and just kind of, I don't know, hero complex or something, I guess. But, having someone also say like, there's only so much that you can do, right? So you can do a lot and don't sell yourself short. And you're a prac student, you're a postdoc, like you can't fix the whole world here, and don't put that pressure on yourself. Do the best you can. So that would probably be one thing that I would be thinking a lot about. um, I would also just talk a lot about the power of our role, just clinically, the work we do and how powerful that can be as um, as a kind of a mover of the clinic culture, just by being there, helping the team with those patients. I mean, I'm thinking of a patient that I started seeing her within a month of starting there, and she'll still be on my schedule. But she would cause a lot of disruption in the clinic overall, like very disproportionate for like one person. And by me kind of absorbing all that, even that all by itself, probably if we could quantify it, probably had a quantifiable like change to the clinic culture. So just kind of empowering students, like even as trainees, to kind of help a lot just by doing good clinical work, I think is a huge thing. And then I would also just, I guess all this is kind of running along this theme of having students not sell themselves short. But I think that when we get into this work and we're around of a lot of other people, like there's probably a selection effect in grad school, right? Where all of us are probably like naturally pretty good with soft skills and things like that. Then on top of that, we get all this killer training, that just puts us head and shoulders above the average person in terms of communication and empathy and, paraverbals and all that kind of stuff, emotional intelligence. And I think we lose sight of that. We kind of forget that what seems so like normal to us is not normal. And that's not something to get like narcissistic about, but it's another way to kind of say like, hey, you have these skills that you're using with your patients. You can use them in your clinic with your coworkers too. And like 101 stuff, paraphrasing and reinforcement and all of these things are pretty like uncommon, among the general population, like awareness of that and skill in those things, unless they've been to therapy or something. But just all that stuff, I think, can really make a huge dent in like a poor clinic culture and maintain a positive clinic culture. And it's all stuff that we already know how to do.
Thank you. I also teach a consultation class, so I'm going to take that back to them about the not selling themselves short, but also like not trying to solve the world, and as well as like taking the clinical skills and using them in different ways, like to communicate and build relationships. So thanks.
And this is related to that question a little bit. This is not coming from someone who has trainees. I was a trainee 3 years ago, so I'm pretty new, but something that I'm still in the process of navigating and learning is, so in our clinic, all of the providers, medical providers, behavioral health, midwifery providers, we all sit in the same room, which is helpful because then we have that constant communication between providers. But one thing that I struggled with when I was first starting out here is this feeling of like, I am the mental health professional in the room and all of this stress is happening around me. And so I feel like I have to either fix it or absorb all of it or something. And so I don't necessarily have the answer to how to handle that, but that is something I think that could have been helpful for me to know a little bit in advance of like, you're going to feel this way and this is what's going to be going on, but it's still not your responsibility to fix everything that's going on around you, which is kind of what Dr. Bruner was saying.
Yeah, I got to piggyback on that. That is yeah, truer words have never been spoken, right? And that's why I said it's like this dialectical thing almost of like you want to try always be trying, but also always be realizing that you can't do it all. And also it's not arguably not your responsibility, right? It's just something we're all awesome people and we know we can, so we do. But there are times when I'm thinking actually of someone on my team that initially we were trying, I was more encouraging this person to help with some problematic stuff going on at their site. And basically between the amount of time and effort it was taking the person on my team and the non improvements in the situation, I kind of told the person pretty directly, like, hey, drop the rope. You know, we were trying to help out what was happening in this site. We were trying to improve the culture. It's not working. And for reasons I won't go into the details, but like I need this person to kind of do a good job with their work right now. And so I kind of said, just drop the rope. You know, anything that you do that's related to your work as a BHC, by all means, but I don't want them taking extra time to like talk to this person and coach them or joining extra meetings and stuff like that when when that's time they could be hustling handoffs and stuff like that. So I think that everything's contextual, right? And it's okay to be like, hey, you know what, this isn't, yeah, I'm part of the team, therefore it's my problem, but also it's not like all my problem.
And something I have to remind myself sometimes, and when we have new people on, I just give this little nugget of like, you are the therapist or the mental health professional on staff, but you are not the staff's therapist. Anything else anyone would like to share today? I really appreciate all of the interaction and involvement.
Yeah, I just want to chime in kind of on the topic of boundaries here a little bit. We had a really interesting phenomenon happen with a new hire recently-ish, wherein they didn't have a receptionist available. And so the BHC was like, oh, well, I can help out a little bit at the front desk. And we had to have kind of a conversation about what does that look like functionally in a clinic? Would a medical provider be helping out at the front desk? And so why do clinic staff think that it's appropriate to pull the BHC away from clinical work and ask them to help at the front desk? Whereas, there's a clinic manager present, there are other options. And this kind of goes back to like, yes, it's a clinic problem, and yes, the BHC could help with that, but then what does that mean for the BHC being able to access patients and provide the care that is necessary? And so we had to kind of process that, work through that, and talk a little bit about boundaries and, what's appropriate in your role.
Yeah. Thanks for sharing that. I think that's something that with anything, like boundaries can be lost and blurred and forgotten about or stepped over. And I think helping people advocate for themselves in these situations, I think is huge.
And you bring up a really good point because, like, I think all of us, when we got on here, we were thinking probably mostly about like, how do we help the clinic culture and stuff like that. But, you got me thinking that we can also be thinking about like, what is the culture like for us, right? And so I've definitely had to deal with similar things where practice managers, staff, providers, again, for the most part, we're extremely lucky here. I want to be clear that we're very well received and appreciated. And like I said, even the students a lot of times are treated like providers. But I've had to deal with stuff where people are expecting the behavioral health people to do things that they would never expect the medical providers to do. Like, I'm trying to think of one where we had to close down or something, and the BHC, one of the BHCs was asked to like call their own patients to like get them rescheduled, you know, and none of the medical providers were asked to do that. And so I had to kind of, you know, just, and it's fine, right? Because we want to be helpful and we're all people that love to help, right? We probably wouldn't be in this job otherwise, but you do have to be careful. I totally agree. You have to be careful about where that line is and what kind of precedents and expectations you're setting, because otherwise, you know, then you're the one that's everyone else is really happy, but you're not. So.
Mhm. Well, we've got just a few minutes left. Any final remarks? This has been a really great discussion. Oh, sweet. Sorry, we're doing construction if you hear something in the background, but I appreciate all of your time. Dr. Bruner, thank you so much for opening up for us and sharing so much. We'll have another meeting in 2 months and we'll get out the topic to all of you in advance, but thank you so much for joining us. If you need anything, reach out to any of us on the SIG. But thanks again. I hope you all have a great rest of your day.
Thank you.
Well, have a great one.
Bye.
Thank you.